Welcome to this Health Foundation webinar, exploring the role of context in improving healthcare. The webinar is the latest in a series discussing aspects of improvement science. My name is Bill Lucas and I'll be facilitating the discussions today. I'm joined by Naomi Fulop. Naomi is Professor of Healthcare, Organisation and Management at the University College London, and John Gabbay and Andrée from the University of Southampton. John and Andrée are both respectively retired professors of nursing and public health. Naomi will start our session by drawing on some recent research supported by the Health Foundation into context. She's keen to engage in dialogue with practitioners about some of the interesting findings of her work. Then John and Andrée will share findings from their research for the Health Foundation into learning communities, offering their fascinating model of the improvement pyramid as a means of better understanding improvement. All the while, we hope you will be sending us your questions and reflections so that once our speakers have finished, we can engage them in debate about these important topics. So, Naomi, perhaps you'd like to make a start.
Thanks very much, Bill. I'm delighted to be participating in this webinar today, and it draws on work I've carried out with my colleague Glenn Robert from King's College London. We've contributed one of the essays to one of this group published just last week by the Health Foundation. It's already receiving positive feedback on their website, and we hope people find them useful. Subsequently, the Health Foundation commissioned us to carry out a systematic review of the role of context in improvement to be published later this year. And what we hope to offer are some ways of thinking about context. We don't think there are any magic bullets in this area. So why does this matter? Why are we interested in the role of context? Well, we know that the results of quality improvement interventions across healthcare systems or within organisations have been mixed and often have been disappointing. Promising interventions which have been implemented in one setting haven't been transferred successfully to another or haven't been able to be sustained over time. With the benefit of hindsight, the usual explanation offered by people is context. So how do we define context? Well, that is actually a subject for a whole webinar in itself. But I'll try and restrict it to this one slide to give you some idea about the range of definitions that are used. Paul Bate, in his essay, one of the group just published, draws on Goldner's argument that context is everything. There's a time and a place for everything. So if I shouted at everyone to leave the room now, that would be rude in this context. If there was a fire going on and I shouted at everyone to leave the room now, that would be perfectly appropriate. The trouble with context being everything is that it can then mean everything and nothing. And Paul Bate in his essay also quotes Noah Williamson's insight that it's a catch-all word, usually used to mean all those things in the situation which are relevant to meaning in some sense, but which I haven't yet identified. Another way of thinking about context which has been used frequently is the gardening metaphor. Rosabeth Moss-Cantor, for example, has talked about 1,000 flowers blooming in this respect in the context of innovations, but it could also refer to quality improvement initiatives. So these 1,000 flowers blooming need a rich, fertile soil, i.e. context, in which to be successful. We've gone back to a definition used by Andrew Pettigrew and others in their study of strategic change in the NHS in the late 1980s and early 1990s, where they argued that context refers to the why and when of change and is concerned with both the influence from what they call the outer context, so the prevailing economic, social and political environment, and influences internal to the organisation, such as resources, capabilities, structure, culture and politics. There's also a debate in the literature about the boundaries between the context and the intervention to improve the quality of care. And we can get into angels on a pinhead here, which is very unhelpful, and I'll come back to that in a moment. And finally, there's a distinction between omnibus definitions that are all encompassing and discrete definitions that kind of try and chop up context into different factors. And the point is that one's definition of context is very much dependent on the theory of knowledge that one is employing. So turning to our review, we were looking at which contextual factors are associated with successful implementation of quality improvement interventions in healthcare organisations. And the questions we addressed were which aspects of context have been found to be important in the implementation of improvement interventions, which of those aspects are modifiable, are amenable to change, what evidence is there that these aspects have successfully been modified and resulted in improvement to quality. And in our essay and in the review, we've drawn on a number of different models of context. And there are a whole range in the literature, as you might expect, given the whole number of different definitions. And I'm just going to refer to 3 here. So the first one is going back to the work by Andrée and colleagues, and they identified 8 receptive contexts for change. And I won't go through all 8 here, particularly as I'm going to be coming back to them. Subsequently, a number of scholars have emphasised or focused on psychological or emotional aspects of context. For example, some of you might be aware of Wiener's organisational readiness for change model, which rather than focusing on readiness of organisations in terms of their structure, it focuses on terms of psychological state in which members of the organisation feel committed to organisational change and improvement. Another one that we found helpful in our work is this one developed by Hui, which is looking at how emotional dynamics influence change dynamics. And we like this one because it focuses on areas which practitioners might might think about quite often, but academics less often. So you'll see issues like love and playfulness here on this slide. And he identified 5 emotional capabilities that are important for an organisation. So emotional authenticity, constructive discontent, sympathy, fun or passion, and hope. So in turning to the methods of our review, which I'm not going to go into in any detail, all you need to look at is the bottom of this slide, where we included 195 studies. It was a very wide-ranging review, and we summarised all of those and analysed them, but in particularly drew on ones we defined as high quality, 17 empirical studies and 2 reviews. And the way we structured our review was, if you look at the left-hand side, you'll see Pettigrew and colleagues' 8 receptive contexts for change. So we looked at all the studies and saw where they fitted into these 8 boxes. In the middle then, we looked at the level of the system at which the study was focusing, whether at the macro, national, for example, regulatory or finance level, at the meso-organisational level, or at the micro-clinical system level. And finally, we distinguished studies which had focused mainly on structural aspects of context, for example, the policies that an organisation has related to quality improvement, and these psychological aspects, so for example, staff commitment to improvement. So what did we find? Well, the majority of studies are large-scale cross-sectional surveys. So, for example, researchers have taken a number of factors, contextual factors, for example, whether hospitals are accredited or not, the level of competition that exists, whether they're teaching hospitals or not, and looked at the association with quality or quality improvement. And most of these studies come from the US, which again raises questions in terms of the context in terms of the NHS, applying them to the NHS. And the most common features of the Pettigrew and colleagues model we found that were studied were organisational culture, quality and coherence of policy, and environmental pressures, external pressures. Most studies are at the organisational level, And the majority of studies focus on these structural aspects of context rather than the psychological ones. And especially at the frontline clinical level, we found few studies looking at the psychological aspects. And there are very few studies which look at more than one level of the system. So what do we find in the way of modifiable aspects or factors of context that were found to be successful? Well, first of all, most of the studies are of factors or aspects that aren't modifiable. So things that relate to, for example, whether the organisation is located in urban or rural area, the demographics of the area, organisational size, and so on. But in terms of those that did look at modifiable aspects, and here we get into the blurring of the boundaries with what might be defined as quality improvement interventions. Just some examples here. The macro level publication of surgeons and hospitals' performance was found to have a positive impact on quality. At the meso level, there are some studies of the introduction of electronic patient records. And at the micro level, multifaceted quality improvement intervention, which included financial incentives, was found to improve adherence to guidelines. So what's the way forward? Well, there have been some recent developments in the field from Heather Kaplan and colleagues who have developed this model for understanding success in quality, which you'll be pleased from the busy slide to know I'm not going to go through in detail. But they've developed this initially from their systematic review of the literature, which only included quantitative studies, and they've now developed this model to be used by researchers, but also by practitioners in thinking about which aspects are most helpful in thinking about context. But we'd argue that now attention really needs to be focused on the psychological, emotional contexts that facilitate quality improvement. And we'd argue it's important to pilot reflective tools that enable practitioners to take account of contextual factors before beginning and while they're implementing quality improvement interventions. We'd suggest that designers of these interventions need to think about all the levels of the healthcare system, the macro, meso, micro, and how they interrelate. And in terms of future research, we'd like to argue that we have all these cross-sectional studies which tell us something, but they're not really helping us move forward. And what we need more of, and there are some good examples now coming out in the literature, are longitudinal process-based organisational case studies, such as those that Andrée Pettigrew and colleagues carried out back in '92, and there are some more recent ones focusing on quality improvement interventions. And Mary Dixon Woods also argues this in her essay in the collection published by the Health Foundation, that by undertaking these studies, it can help us focus on the necessary and sufficient conditions, she argues, for change and improvement to help us think about context. And one such study we've carried out recently is indicated at the bottom of this slide, the Quasar Study, which is a study of organisational and cultural influences on quality improvement in hospitals in 5 European countries. Where we used 8 challenges for quality improvement. And that link there, that slide is to the guide, which I'll show you in a moment. So these 8 challenges build on the organising for quality work that Paul Bate and Glenn Robert and colleagues undertook some years ago, where they identified a number of challenges common to high-performing hospitals. And we've added 2 to their original 6, leadership and managing the external context. And this is an example of one of these reflective tools that I was talking about to try and help practitioners think about which aspects of context they need to focus on when developing and implementing their quality improvement interventions. And we want to emphasise that this is a heuristic. It's a way of thinking about these different aspects of quality, whether they're cultural in the red circle, or emotional in the white circle, or blue, the blue circle, which indicates structural. They are, of course, all highly related. And when one's thinking about, for example, the physical and technological aspects of context, be they electronic patient records or use of scorecards, for example, we need at the same time to think about what the impact or what support that would need in terms of the emotional aspects of context, the cultural aspects of context, and so on. And so just to end then, I'd like to flag, if you're interested in that way of thinking, this guide, the Quasar Guide for Hospitals, where you can find more information and how to use these 8 challenges. Thank you very much.
Naomi, thank you very much indeed. And some questions coming in already. Do please feel free to ask questions. We've already had something about the work of Kaplan and colleagues, which in fact Naomi went on then to talk about, which is a good sign. Naomi, I'm curious, what did you find in your research that surprised you?
I think the thing that surprised us the most was this lack of studies at frontline clinical services that looked at these emotional, psychological aspects that I talked about, and that really does seem to be a gap.
Okay, thank you. And that might be a point of connection between what you're saying and what our next 2 speakers are going to be arguing. So let me now, without any further ado, it's my great pleasure to ask Andrée to take over the clicker.
Thank you very much, Bill. Thank you, Naomi. Thank you very much for joining us today. I'm very pleased that you're also with us here, if not in person. And we're going to talk about some of the skills that we observe people using as they weave their way around various contexts in order to make improvements. This is a project that was conceived by the Health Foundation, and they hoped by us undertaking this project that we would be able to begin to understand better how improvement, largely using proven improvement methods, came about in high-performing organisations, and how improvement science became part of organisational learning rather than just simply being at an individual level. We also wanted to explore how learning communities and communities of practice worked in these situations as well, in order to help bring about improvement. So there's been much debate about improvement science, but here we're taking it to mean proven improvement methods. For instance, PDSA cycles, care bundles, lots of these things you'll be very familiar with. But also these things are underpinned in this situation by a particular philosophy. And that philosophy is really revolving around working with the willing and early adopters, using clinicians' own data, bringing about mutual problem solving, focusing on improvement conversations rather than punitive techniques, and focusing on 1 or 2 agreed problems rather than what's become known as a spray and pray approach. So these techniques often included doing small tests of change and adjusting as you go, seeing how things work and making them relevant to the situation in which you're working, showing just enough evidence to make the point, developing ideas of improvement with clinicians, and getting buy-in and ownership through early wins and natural spread. Let me tell you a bit about the sites that we worked in. 2 exemplary quality improvement sites were chosen. We worked with them between 2011 and 2012. And in each of these 2 sites, we chose 2 improvement groups to study in more depth. The first site we'll call Fern Hills. Now this site, quality improvement really was exemplified through excellent performance management and commissioning. The projects in this site focused around chronic obstructive pulmonary disease and dementia. Dansworth was a little bit different. Here, the aim of the senior management team was that quality improvement will be hardwired through every employee's mind. So it was quite different, and they had numerous opportunities for education and training around quality improvement and leadership and change management. The two projects that we focused on here were around elderly care, and in this instance we were focusing on estimated dates of delivery and, once again, dementia. Now, in studying these sites, we used several methods. First of all, we got to know the sites better by a couple of orientation visits to each of the sites, lasting largely around a week. And at those visits, we chose the topics with the participants that we would go on and study further. We started off by talking with key participants and then asking them to select people through snowball sampling who would form then an improvement group. We then interviewed members of this improvement group using something that we call spyback, which is basically an interview-based analysis of things that were going well and things that were causing concern. And from that, we tried to prioritise what was needed to further the improvement task. We used a nominal group technique to do this. After that, we clustered and manufactured, if you like, in conjunction with the improvement groups, a series of learning events, sometimes to introduce improvement techniques, but in other instances to introduce, let's say, softer skills that were needed, such as assertiveness, to persuade people to improve. Sometimes, some instances, it was necessary to do further interviews to find out more, but in the main, this wasn't necessary. We did 9 learning events in total, and at the end of the project, we did some follow-up interviews. Each of the learning events was facilitated by one of the researchers, and although we were there facilitating, we were also there watching what was happening. So we began to gather up a rich picture of the culture and the way people worked in these situations. I'm going to tell you just a little bit more about each of these sites before I hand over to John. I'm going to give you a little fraction of information about them. There's lots to read in our report, which will be coming out soon. So COPD at Fern Hills hope to reduce hospital admissions and also to provide community-based rehabilitation, generally to make better the lot of people with COPD. This group was highly successful in achieving its outcomes, but unfortunately it achieved outcomes in a way that it wasn't very happy with, mainly through performance management, mainly through commissioning, because this was the way improvement was done in this site. What this group really wanted to do was to try and use some of the techniques that the other site were using, to work with clinicians, to focus on what was happening well. And this developed into a real tension between the techniques that were available and the techniques that were, if you like, espoused by the organisation. In the dementia group, they suffered from other problems. They did achieve their outcomes, which was reducing the waiting time in the memory clinic, but they never really got together as a group. These things seemed to happen outside the project. And eventually, as the project closed, this group of people did have one meeting, and it was astounding that the majority of people at that meeting, again focusing on GPs and memory and diagnosis, hadn't met before. So although they didn't function as a learning group, they, at the first meeting, towards the end of the project, did then begin to have some embryonic connections and networks that they hadn't used before. In Dansworth, this is a project that started late because of ward closures and service disruption. They very quickly formed a very cohesive and coherent learning group, and they focused on estimated date of delivery. They achieved their original objectives and went far beyond their remit by doing something that they thought was originally impossible, and that was involving community and social care staff as well in coming to a determination of estimated discharge dates. And finally, in the dementia project in Dansworth, it originally started out focusing on how we might improve the hospital environment so that that was better for people with dementia. But actually, once again, it seemed to stall at the beginning. And eventually, as the project closed, we had 2 learning events. But rather than focusing on the hospital environment as such, these focused on how it would be best to train nurses, doctors, healthcare assistants, so that they were better able to communicate and care for people with dementia. I'm going to hand over to John now.
Thank you very much. For those of you who were confused, Andrée said expected date of delivery. Of course, you meant discharge. Expected date of discharge. You can tell that she used to work in maternity and family planning. I'm going to just try to pull some of this together as a way of drawing out some lessons from this. And you probably noticed already that what we actually did inadvertently was to create a natural experiment where the COPD group were very keen on the improvement science, so-called, that we were trying to introduce, but were prevented from really using it by the broader organisation that had a different view. And the dementia group were trying to improve things without getting together as a group until the very end, when things really did begin to motor because we'd got them together as a group. Whereas the elderly care group in Dansworth, with their expected dates of discharge work, were extremely well versed in the methods that Andrée highlighted earlier on in her talk, and had that philosophy, that underpinning philosophy of working with the willing and pushing things forward that way. Whereas at the further reaches of that organisation, literally geographically and indeed in the sort of community dementia services and so on, which was eventually where we ended up doing the work rather than just the hospital, they hadn't really been touched as much by the underlying improvement culture that Dansworth was so good at. So the external context for the group was very different in each case, and there were other differences as well. One was in England, and therefore there was a great deal of change of the management structures, whereas the other had continuity of management. The managers who had put in place that underlying culture at Dansworth had been there for literally a decade or more, most of them, and had really inculcated that into the organisation. And as Andrée said, and in fact as one of our interviewees said, hardwired our brains into thinking about that philosophical approach to improvement, whereas the other one was much more part of the NHS culture of targets and performance management. So the external environment to the group was important, but also that was because of the external environment of the organisations, who themselves were subject to very different pressures. So there is a big relationship between the external context, the external environment, and the internal organisational culture of improvement that we're talking about in the groups that we were working with. What do I mean by organisational culture? Well, I'm talking really, if you turn that into operational things, I'm talking about the resources that are thrown at this. Now, in Fern Hills, they were mainly putting their resources into the commissioning process, into the measurements of targets and the performance management, whereas in Dansworth, they were putting their resources into training people in leadership, in people skills, in the techniques of improvement, and putting in place structures and processes, training what they call improvement fellows, and it was indeed one of those who made the expected date of discharge work so well, and processes that were conducive to the kind of thing that the Health Foundation were trying to promote. This, of course, means different styles of leadership, and it means working one's way through the local politics in very different ways, and we saw lots of examples of this, which we can't go through now. But the local politics, for example, was what got in the way of the kind of improvement that they had initially wanted to do in the Fern Hills dementia work. And of course, all of that eventually falls down into some of the things that Naomi was talking about the psychological, the relationships, the trust and communication, how much people value each other's work and trust each other's opinions. So the pyramid that Bill alluded to earlier really has 3 sides. A pyramid with 3 sides that has, on the one, there's the technical skills, that Andrée showed earlier, things like run charts, and they can be quite simple technical skills, or they can be quite complex, like statistical process control and so on. But while we were initially hoping to help people to introduce those, what we found was that unless they had the soft skills, the psychological background, and social psychological, the social skills to make that work, the organisational skills, then the technical skills were just never going to happen. And perhaps the surprising third side of this pyramid is that they need to be able to learn to do that. They needed to be able to work as groups. And the base of the pyramid is, of course, the organisation, the culture and the structures and the processes I was talking about. You cannot build a pyramid without a sound organisational base, and this is what we found, for example, in the dementia or even the COPD project in Fern Hills, because the organisational base was not conducive to that kind of thing. So here's the famous improvement pyramid, or it soon will be famous when the report comes out. The first side, the first thing to say is that you can't have one very tall side of a pyramid and get to the top unless you also build the others. There's going to be a lot of wasted resource you're putting in the technical stuff when people haven't got the social skills or the learning skills to actually make that happen. So there's a wasted resource because the skills fall short on one or more sides of that pyramid. So you won't be surprised to hear that what we're arguing is that whilst it's very important to have the technical skills, which are that pink one on the left. On the right here you have things like time management, simple things like how to prioritize your work, how to decide what to work on, the organizational administrative skills, the knowledge management, the negotiation skills, the political skills, the leadership, and so on. And as we all know, you don't just learn those as an individual going away and reading a book or being lectured on. You have to work as a group in a learning organisation, working in communities of practice, in learning communities, and sharing knowledge. So the implication of all of this, and I hope we'll be able to go into that much more when the questions come, are that the organisational and personal skills are essential if you're going to be able to deal with the context, and they're a precursor. They are as important as the hard skills of improvement science that the Health Foundation were initially hoping to introduce. And learning communities are a good way to do that. Learning communities don't just happen, they have to be facilitated. And if we're going to get sustained improvement, then we need to be able to work on those soft skills and those learning skills. And we actually found that the spyback process, the interviewing and prioritization work really helped to make that happen.
John, Andrée, thank you so much for that. And thank you for the questions that are now indeed coming in thick and fast. We're going to start with just a very practical question because it's already been asked and the answer was being offered by John there. So John, what might the practical implications of that fascinating pyramid be?
Well, I think it's about where you put your resources in terms of trying to manage an improvement process, in trying to bring about improvement in a particular part of the organisation. If you try to simply train people in using the technical skills without putting an equal amount of resource into helping them to learn together, to work together as a group, to develop those touchy-feely soft skills that are so important and that Naomi's work has also demonstrated, the psychological side. If you don't do that, then you're likely to fail and to have wasted a lot of resource in doing it. So the practical implication is think about how good are the soft skills in that part of the organisation, how well do they actually function as a group, and think about that at least as much as you're thinking about let's put some run charts on the wards and make them hit targets, because you are more likely to achieve what you want if you build all three sides of the pyramid and have that organisational base that takes that seriously and puts resources and processes and people in place whose job it is to do that.
Does that resonate with you, Naomi?
Very, very well, actually. And I mentioned our Quasar study, and what I didn't have time to do, but it's nice to be able to do now, is in terms of what we found across the hospitals across 5 countries in Europe, is that most of the emphasis, they were paying attention to these hard, the structural, the technological, the technical aspects of quality improvement, and much less to the cultural, emotional aspects. And in fact, that was particularly true in our English case studies. And that's where this relationship between the external context and the internal context is so important. Because of the performance management target culture, senior leadership teams were busily managing that and it meant that they didn't pay so much attention, which I think they are now, post-Francis, to these emotional, cultural, educational aspects of improvement.
And interestingly, there's a specific question for you, which is an analogue to that last one. You mentioned a practitioner interest and practical tools that might arise from your own research. Could you just talk out loud, how might, at the very practical level, how might a practitioner take forward the kind of things that you've been discovering?
Well, for example, I think it would be really interesting for practitioners to pilot some of these models, and I don't want to push one more than another. I think it's for practitioners to look at sort of 3 or 4 of them and work out what might be most helpful in their context, and actually use it as a reflective tool amongst their team. So I can talk about the Quasar one because that's the one I know best of all, to say, okay, we've been paying attention, for example, to data, to electronic patient records, for scorecards, run charts and so on. What do we now need to be paying attention, and how might we do that? And we offer some strategies to help people think about that, and also some examples from our 5 countries. That's one way they make. There are other models that I've pointed to and that you can read about in the essays that you might want to use in a similar way. So it's about what you referred to, Andrée, these improvement conversations. It's about sitting down, reflecting, self-assessing. Where are we now? Where do we need to move to next?
So some of the tools might be a sort of roadmap and an ongoing reflection guide to progress.
Exactly.
2 questions which I'm going to combine. Invite you both to go a little deeper. I think, I haven't counted, but I think there were probably 12 items on each of the pyramid signs, which makes 36. And I think there were 8, possibly expanded to 10 factors in yours, Naomi. And listeners and watchers are really just interested in your sense of priority and your sense of whether anything stands out, or your sense that as you've laid them out, let's start with John and Andrée, whether do the skills that appear at the bottom of the pyramid, are those building blocks, or is that just a graphical accident?
Do you know, it's a graphical accident. But in terms of priority, if we're thinking about the soft skills, what we did note in in 2 of our 4 groups, and they happen to be the most successful groups, is that participants really needed skills in communication and assertiveness. They needed to work out how to persuade other people, how to negotiate, how to weave their way through the political quagmire and context within which they're working. So if I was to pop one up at the top, that would probably be around about negotiation, communication, assertiveness, and also leadership. If we think about leadership as something to do with influence.
Okay, so
that's where I'm
bringing others along
money.
to your viewpoint, advocacy,
yes,
making a compelling proposition.
Absolutely, and also encouraging ownership, because none of these things are going to work unless people actually own them.
Okay.
And of course these rely also on people's ability to read other people, to understand where they're coming from. Those really important negotiation skills, which are not about getting your point across, but about understanding why other people don't want to hear your point, and understanding how you might actually be able to negotiate a way forward that they're happy with and that they'll go with. And those are the sorts of skills that are not always natural to people, and that we're advocating a certain amount of help and training with.
Yes.
Which does often involve group work, of course.
Yes.
And on the learning phase, I think it's important to think about learning from each other. Sure, it's great to reflect with other people, but people do have really important experiences that they can share that can either stop people making mistakes or actually encourage them in particular ways. For instance, focusing on the positive rather than being punitive was an important thing that we kept hearing.
Okay, thank you. Naomi, is it invidious to ask you to pick 1 or 2 that seem more important, or is that not a good question for you?
I guess what we're offering in these 8 challenges is a way of people thinking about, for them, what they need to focus on. But if I was going to pick out a couple, and I agree very much with what Andrée and John have been saying, but for example, in terms of managing the external environment, what we found was that in this case hospitals, were more successful where the senior leadership team turned all these external demands into something positive and used it as a way of building a collective culture for improvement, rather than seeing them as burdensome, which we know they are, but actually turning them into something positive. So that's one I would add as particularly important within our English NHS context.
Okay.
Can I just say,
of course.
I don't think we should forget the learning skills side of the pyramid either, because people, particularly in the health field, or particularly on the medical side of the health field, are very used to didactic teaching. They're not used to learning from each other, learning with each other, understanding other people's knowledge and perceptions so that they can develop a common view of things. They're used to being told what to do, and actually the soft skills stuff doesn't happen through that kind of didactic teaching. So there's very important to look at the learning pyramid, the learning face of the pyramid as well.
And of course, it's very important to think about learning when we think about challenging as well. I mean, increasingly it's important not only for people to learn, but to be critical and challenge other people's practice.
So there's a question here that would seem to play very much into that discussion. It's this. Do you think learning communities could be usefully targeted at making improvements in emotional, psychological and behavioural issues and better working across disease types?
I shouldn't give a one-word answer, but yes.
That's fine. No, well, gratefully accepted one word. Yes, because...
Yes, because staff, as well as the clients and patients, need to be able to handle those sorts of things. And the environment is often, and the context, let's use the word we're using here today, the context is not always conducive to being able to handle those things and talk about them and take them forward. It's often about burying them or pretending they're not there, or taking refuge in the technical, and that's not going to ultimately get you anywhere. So yes.
Yes. And another quite technical but also a question of general interest, Andrée, maybe to pick up on this, you talked about the importance of positive. A questioner here wondering whether you used appreciative inquiry as a tool.
No, we didn't use appreciative inquiry as a tool here at all, but other people have. And I'd say that it does give you a kind of good structure to work with, doesn't it, when we're thinking about trying to expose the positive. Having banged on about exposing the positive, we mustn't forget that it's also important to expose the things that aren't going so well, the concerns that people have as well.
Thank you. And just staying with your researchers for a second, some methodological questions I think are of general interest here. Question about how you chose your exemplary sites. Was it through data, through self-identification, through recommendation? And a related question about the kind of improvement data that you were interested in. The question reads quite simply, did the analysis also include objective improvement data?
Right, can I take that one? The selection of the sites was quite a long and rigorous and complex process that the Health Foundation had initiated before we were even commissioned to do the research. They shortlisted 25 organisations in the health service in England and Scotland through their networks, basically asking, can you recommend places that you think are really good at quality improvement? And we then solicited, or the Health Foundation solicited, bids. People had to write a proposal and say why they were a good quality improvement place, what they wanted to do and what they wanted to get out of this project. We had a sort of a selection panel, if you like. We had an interview with one of the sites. One of the sites was almost so far ahead as a front runner before we started that they didn't even go through the interview process. That was Dansworth. The other was pretty much head and shoulders above the other 24. So the selection was very much on the grounds that these were regarded at all levels of the health service and the Department of Health and the Scottish Office as being among the leaders, if not the leaders. The other question was about objective measures. Well, yes. We're qualitative researchers, so that's a tricky question to answer. But the reality is, yes, we did, for instance, with the COPD group, the chronic bronchitis group, we got them to give us the figures of how things were changing, but of course one can't attribute any causality to that. And similarly with the dementia, we were watching the waiting lists fall, and we also saw that the numbers of patients referred to the clinic were changing. So yes, there were some, but that wasn't really what our project was about. We're qualitative.
Whilst we're qualitative, interestingly, the people in the improvement groups weren't quite so qualitative, and they did have outcomes that they followed. They did look at how many people did have an estimated date, and I must get it right, it's discharge. How many people actually were discharged around that estimated date? What proportion of success then did they have? In terms of the 2 dementia projects, it's hard to identify hard data, except that we know that through no help from us, the dementia project that was focusing on waiting lists did actually achieve a reduction in waiting times. Again, hard data, not gathered by us, gathered by the improvement groups, which is exactly what you'd want.
Yeah, it's worth saying that although we appear to come over as touchy-feely qualitative people, good improvement does have to rely on proper measurement. You cannot do improvement without measuring where you are now and how you're improving. There's no worry about that. But that wasn't what we were actually measuring. That's what the groups were measuring.
I think it was a genuinely, I can't tell, but it felt like a neutral question, and it's elicited a mixed methods answer. So thank you very much. Now, there are 2 questions, one of which unites your research, and one of which is deeply philosophical and may need some thinking about. So I'm going to give you the second one first to give you some thinking time. Some scholars have proposed that context is an emergent property of systems, hence time dependent more than a static property. Does this make sense? And if so, can it help in developing effective improvement interventions? So hold your thoughts on that, please. And then the second question is around what appears to be some common ground in the development of emotional capability at the organisational psychological level and at the individual level, and in the middle to where teams operate. And I'm going to just pass the baton to Naomi to take either of those questions, if she'd be so kind, and then we'll invite you to respond, and then we'll have a go at the other one. What would you like to go for first, Naomi, there?
So can you just remind me of the first question?
The first question is a notion of, I guess it's complex adaptive systems thinking. Context is itself an emergent property. Therefore, it's not static. Even trying to draw it in the way that we were drawing it is challenging. Yeah. Does that line of thought carry weight with you? Yeah. And could you just talk through where that would take you?
Okay, so no, this is a really helpful point, and I particularly direct people to Paul Bates's essay in that collection, because he deals with these questions really nicely. And of course, there's tendencies, he argues, to kind of reify context. It's a thing that you can touch and describe and draw, as you said, Bill, which in a way, of course, you can't at all. But if you went completely down that line, you wouldn't be able to talk about it at all, which I think wouldn't be helpful for people out in the field. I think they want to find a way of talking about it, naming different aspects of it. And I think that's what all these models, some of which I referred to, are trying to do. And none of them will be perfect. And absolutely, it's dynamic, it changes over time. And that's why we're suggesting, along with others, that we need longitudinal studies, not these cross-sectional studies that look at attempts at improvement over time. And the context will change, and the interaction, the dynamics between the different aspects of context and the intervention will change. So it's a really, really good point.
So and just before I come to John, you used your own distinction of the macro, meso, micro. Even in that sense, is it meaningful to think of an organisational entity as having a context, or is it always going to be a plural?
No, it's always going to be a plural, and that distinction in of itself, we know, is, we're trying to cut a cake, and it's not very helpful because, of course, the lines are blurred and you need to look at the interactions, but it's a way of helping people think about all the aspects they need to think about, if you like.
Okay, thank you. John?
Yeah, I mean, I'm very happy to answer a philosophical question about science. I happen to have a badge in that sphere. Everything is very complicated, everything's changing, everything is unmeasurable, infeasible as a scientific place of inquiry until you start to break it down into always artificial bits and pieces. Atoms and molecules are artificial in a sense because they don't really exist like that. But you have to do that in order to be able to study them. So of course it's artificial, and of course it's very complex. And it's bound to change, and yes, it does emerge from the system. But the other thing I'd just like to add is that as the organisational context changes, so the context changes the organisation, which then changes the context. So these things it's even more complicated because they are feeding each other and changing each other as it develops. But you can't study something like that unless you break it into admittedly artificial bits and pieces for study.
I guess most researchers in this field would say that simply by trying to make any kind of improvement, you're yourself part of a process, complex process of changing the context, and you're part of that context.
And we were quite explicitly so.
That came across very clearly, actually, in your. And one of the questions was, I think, related to that. At what point did you feel that the 4 groups that you were working with, if they did, achieved ownership, and in a sense, your facilitative introduction was becoming less important and they were really owning it?
Yes, there were 2 groups that I think achieved ownership, the COPD group and the estimated date of discharge group. And I suppose we saw a change when they were asking us if we could do things for them. So could you arrange this for us? And the ideas were really coming from them. That's really for the COPD group. In terms of the estimated date of discharge group, what happened there was that they actually said they achieved something they never believed was possible. And certainly facilitation was essential because the facilitator was on their case, if you like, to try and keep that thing on the agenda. But once they realised it was possible to do it, they organised everything around that learning event, and they expanded their improvement group to include people from the community and social services, and we knew nothing about it until the follow-up interviews. So yes, they achieved ownership big time.
So questions now about the graphic that you've chosen to go for the model. Inevitably, whatever model you go for, it's going to invite a dialogue, shall we say. A nice point suggesting that a spinning top might be a better metaphor, and some nice suggestions about what could be on its sides. But a really interesting question about the confidence with which you're placing certain elements as positive elements on each of your 3 sides. What process did you go through that would support an enthusiastic skeptic about why any of those elements should be on any one of your 3 sides?
We are researchers. We analyse data carefully and rigorously. We went through a process of sifting the information we were getting from the interviews, from the observations, from the participant observation that we were also involved in, and from the documents and so on, and the data they were feeding us. So we went through a process of proper research, qualitative analysis, which is the best you can do in this circumstance. We didn't just pluck these ideas out of the air, or still less from our heads before we started, because we were not expecting to find this. We were expecting to help these groups to introduce technical improvement methods by bringing in external expertise of those technical methods as and when they needed them. We found that side, the other sides of the pyramid, as it were so low that there was no point in doing that. They simply weren't able to or willing to ask for that sort of help until they got the other stuff sorted out. Andrée may also want to add to
and
that.
also we checked out these ideas with the participants after we'd finished the project. We did have lots of different ways of doing things. We had ropes being plaited, and spinning top would have been a great idea, but we didn't have that. And the pyramid seemed to work because it allows you to think about the 3 sides and the importance of them all being built to the same height if things are going to work.
And I like the idea that it's grounded on an organisation's ability to be ready. And that's the link I want to come back to, really, because it seemed to me, as you were both speaking, there was a sense in which you were describing the psychological and sociological features of an organisation that's ready enough. You'd chosen some, in a sense, through recommendation, high performers. You'd used the literature to get to the essence of high performance. Can you read across to each other's work and see connections and see possible next steps at the very practical level Because that's what a lot of these inquirers want. They want reflective tools. They want precisely the ideas that you've come up with so far. Naomi, just think out loud on that.
So I think where there's certainly a connection is that the work I certainly presented at the end in terms of the Quasar model is originally aimed at senior leaders of organisations, although it could be used potentially at any level of the organisation. And the work Andrée and John have been talking about is at kind of the team level. But there's a lot of read across in terms of the kinds of skills, whether you call them skills or challenges. There's a huge amount of read across. So I think they're very complementary.
Thank you.
I think they are. Certainly the point you've just picked up on, that if you go to any of the literature about quality improvement methods, about change management even, it's always aimed at the senior managers. And actually it's the troops on the ground who are working in these teams, either explicitly as we did it or implicitly and informally as tends to happen in organisations. They're the ones who really need the help. So one of the things I think we should take forward is how can we give the necessary help and tools to people at that level working in organisations to help make the changes they want to make. And can we please focus some more research and some more development of tools and methods that are aimed at them and not at the bosses who think it's all hunky-dory, but when you get down there you find it's actually very different.
And can we also think a little bit beyond, oh well, if we have a tool it'll be okay.
Yes.
Because also if we're aiming at frontline practitioners, we also need to think about the people that teach them through continuing professional development, through initial education and training, and to begin to think about how the skills that we found, the 3 sets of skills, can actually be embedded in curricula and also other learning opportunities.
Okay. Just a quick specific for you, Naomi. Were you surprised by the fact that the Quasar research had to highlight the role of leaders and leadership as one of the fundamental traits of high-performing organisations?
Well,
This is one of your extra challenges, I think, isn't it?
we pulled that out as a specific challenge. It wasn't that it wasn't in the original set in Organising for Quality. They had built it throughout their other challenges. It's a different, these are heuristics, these are a way of thinking about things. So we specifically, in this case, wanted to pull it out as a specific thing to think about. And it's leadership at all levels of the organisation, not just at the top.
Okay, so we're moving to a close now, but before we do, we've just got time for a few more couple of questions, and one that's challenging, I think, is we've talked about the organisational level, indeed at individual level. What would you like to just think out loud? What might the macro implications of your research at the system level, the bigger system level, be? Naomi.
I think what I'm saying is that the macro, the top of the shop needs to think long and hard about the culture that its structures, processes, policies are creating. Because what was, and I think is what's clear when we present the findings from the English part of Quasar is, and it gets a big laugh. Sadly, is that it has meant people focusing on managing targets as important as they are, but paying much less attention to these other issues that we've all been talking about today.
Thank you, John.
I couldn't agree more with that. I mean, don't get me started on why the macro shouldn't get involved, because
I can't get you started because we're very close to finishing.
It's very important to recognise that the top of the office should not be trying to impose things at a whim, even if they think they're a good idea, because it doesn't work like that. And changing structures and imposing new structures and new cultures isn't going to succeed. It has to come from underneath and from the groups we're talking about.
Thank you. Andrée,
and
last word.
As we've said, excellence is about having a strong organisational base and paying attention to all 3 sets of skills. It's no good over-egging one without attending to the others.
Thank you. Well, thank you, colleagues, for watching, and most importantly, thank you to Naomi, to John, and to Andrée. You can already have downloaded the resources from the site, and if you're on the mailing list, we'll be in touch with you because there's an exciting programme of webinars like this throughout the rest of the year. And finally, it just remains for me to urge you to go and read some of these things that have been mentioned. Here's the lovely piece on context, and here's a piece called Effective Networks for Improvement, all also available on the Health Foundation website. Colleagues, Naomi, John, Andrée, thank you very much indeed for taking part.
Thank you.
Thank you.
Thank you.